I would like to thank the Saudi Society of the Periodontology, and also in the collaboration with the Saudi Endodontic Society. This topic is mostly the hot topic nowadays for the dentists, because they want to know what's the type of endodontic emergencies. Yesterday, there was a good lecture by Dr. Yusra Khairallah from the Saudi Endodontic Society, and it was about the COVID-19 under the endodontic emergency. And she went through the precautions and the measurement. Now, the Saudi Endodontic Society, they made a good announcement that they are going to do a protocol, not only for the endodontist, but also for the dentist, and how to manage nowadays the emergencies, especially with the endo emergencies and the protocols. So this is a good achievement, and that's why this lecture is mostly about basics in the endodontic emergency. It's not about the COVID-19 precaution or the protocol. So this will come from the Saudi Endodontic Society as a recommendation. So when we talk about the endodontic emergency, what do we mean by the endodontic emergency? It's more like, sorry, the screen is still. So the definition of the emergency is something that's related to the pain and swelling. That's the emergency when we have it in the endo. And we have to differentiate between the emergency and the urgency. Now, when a patient has a falling filling or a crown or just a chipped tooth, okay, that's an urgency, okay? It's not an emergency if it's not considered with pain and swelling. So we have to differentiate nowadays when it's considered to be an emergency or going to be as an urgency. When we have the types of the emergencies, we have three types. One is the pre-treatment emergency, and two, we have the inter-appointment emergency, and we have the post-obturation emergency. What's the difference between them? The pre-treatment emergency, that means the tooth that no one ever had touched. Maybe there is a simple filling, but no one has went inside the pulp and did any procedure inside the pulp. And that's what we consider a pre-treatment emergency. And most of these cases will be a vital tooth or a necrotic tooth. When you go with the inter-appointment emergency, that means the emergency that will come in between the visit or after the first visit. That's after you went inside the pulp or someone else went inside the pulp, then came to you as an emergency. Now, the post-obturation emergency, that means there is a tooth that already obturated, maybe in a week or after a year or after 10 years, and that came as an emergency. We will focus more on the 1 and 2, which is the pre-treatment emergency and the inter-appointment emergency. We say, we give you like a quick tips, okay? This is more to be a tips lecture, more than details. I will not go with the state of the art, the books and anything. No, I'm giving you a clinical tips how to manage the situation. When we have the what we call flare-up. Flare-up, it's called or considered with the inter-appointment emergency and the post-obturation emergency. We don't say flare-up for the pre-treatment emergency. Let's go in detail about the pre-treatment emergencies. We have the pre-treatment emergencies considered under the symptomatic irreversible pulpitis and necrotic pulp. Symptomatic irreversible pulpitis could be with normal periapical tissue or could be with symptomatic apical periodontitis. Necrotic pulp could be with localized swelling or no swelling or with diffuse swelling. Each of these has a criteria, okay, and how we can manage the emergency at that time. Going with the symptomatic irreversible pulpitis, first with the normal periapical tissue. And that's the difficult part because the patient could be pre-medicated and would not give you the sign and symptoms that there is any apical problems. And we are using 2D, okay? You will not go with a CBCT just for examination, okay? In these cases where the patient has an irreversible pulpitis. So the most common with these cases with the periapical or normal periapical tissue, the contact of the lamina dura, and there is no tender to percussion. So the patient doesn't have any pain, okay? But you might ask the patient, did you take any medication before you come to me? Because this could mask the percussion and palpation. So these condition, or these consideration, we have the treatment, and then we have the analgesics. What type of treatment we could go and do with these cases? We can go with a pulpotomy. Pulpotomy is removing only the pulp chamber. Or we can go with a partial pulpectomy. That means removing part of the pulp inside the canal or removing the biggest pulp, like going with the upper palatal or lower distal. These are the things. And then you can use like a sodium hypochlorite to clot the bleeding for 2 minutes, and then after that you can close it. The ideal for all situations. Maybe there is a debate about this. Yes.
Would you slow down, because most of them, they are commenting about the you are going fast.
Okay, I will be very slow. Okay, because I have many material. Okay.
Thank you.
So with the pulpectomy, okay, what we have about the pulpectomy, these procedure, okay, if you have time, it's ideal to go for pulpectomy in general. Okay, pulpotomy is for special cases and consideration that will go through it. If the patient is not tender to percussion, you may go with a pulpotomy, okay, or partial pulpectomy. But the ideal, okay, you might go with the complete cleaning and shaving is the ideal. Nowadays with the COVID-19, we might go with the pulpotomy, okay, just to reduce, okay, the amount of the aerosol that will come to you from the patient or from the aerosol that will come from the handpiece. One of the recommendations is to use the rear vent handpiece, which is used in the surgical. We are using rubber dam as usual. So all of this one will minimize the cross of the contamination. Yesterday's lecture with Dr. Yusuf was perfect, okay? That gives you many of the tips and tricks, okay, that you use. Some of them used from the pedo, okay, which is like the decay arrested for the decay that you can excavate. Then after that, you can go inside the pulp and do the pulpotomy. So these are the measurements that will precaution that will come from the Saudi Endo Society. Going with the symptomatic irreversible pulpitis with symptomatic apical periodontitis, okay? That means there is tender to percussion. So in the cases like this, we have the treatment plus the analgesics. Now, if you see that I didn't mention any antibiotics yet, we'll see by the flow of the treatment, how it will go, and when we can go with the antibiotics. First of all, okay, it's tender to percussion. The first thing you will do is go by occlusal reduction. That means you make the tooth out of the occlusion. Second, you'll go with the pulpectomy. Now, how much you can remove? 0.5 to 1 millimeter. Some will say it's aggressive. No, okay. You don't want to only just remove the points, okay, that it's high or anything. No, you want to make it clear for the centric and the eccentric movement. You don't want the tooth to be touched by any of the opposing of any kind of the teeth. Do we have a support for this? Yes, we have. For the occlusal reduction, okay, this is a good study by Dr. Rosenberg. And they found in a cases with the irreversible and with the symptomatic apical periodontitis, occlusal reduction could prevent the postoperative pain. And these are good tips, okay, for you for the further thing. Because when you remove the occlusal, okay, and you remove all the discrepancies, okay, the contacts, okay, that you will have later on, because what's happening really when there is inflammation in the apical area, the patient itself, okay, when he bites, he said, I have pain when I bite. And you think of it, why he feel only that tooth? Actually, the PDL at the periapical area is swelling and it's elevate the tooth. The tooth is higher than the neighbor teeth. So that's why he feel like there is something specific about the tooth. So we need to make it out of the occlusion. Some will say, I'm not going to do a crown later on. That tooth will go and over-erupt. So anyway, we want to make it as an emergency. We want to remove any discrepancies that will make the patient come again, or remove any pain that will happen after the patient leave the chair. This is about the symptomatic irreversible pulpitis and the types that we have. We are now looking for the necrotic pulps. What we have in the necrotic pulps, we have the localized swelling, okay, and these are tender to percussion. Treatment plus analgesics. We go with the occlusal reduction, and we go with the pulpectomy, and then we go with the pus drainage. How we will do it? First of all, we'll try through the canal. We'll go with the file, we try to bypass the apex, and we'll see if there is any drainage will come. After that, we'll go with the incisional drainage, okay, from outside. We'll see if there is a swelling, and it's a fluctuant swelling. Now, do we keep the tooth open after that? No. You should make the pus drain from the canal under the rubber dam till it's clear, then you close the tooth. Don't ever make the patient go out of your clinic with the tooth open. Some will say that patient will come again with pain. If you clean and shape, especially like these cases, you need to go with a bigger size. Size 30, okay, in the cases like this, you might have an apical resorption. So you might go with bigger than size 30, okay? And you need to disturb the apical bacteria or the biofilm in that area. Some will say, okay, the pus is still draining when I come in the next visit. Yes, because you didn't do a good clean and shaping. You need also to place a calcium hydroxide, but don't ever keep the tooth open. Some will say, okay, aerobic and anaerobic. No, it's not clear or it's not true, okay? You need to clean and shape, and you make sure that whatever you place inside the canal and you close it and just follow the patient. Most of the time, if the patient will call you for an emergency, you will see him the next day or the after day, you open and clean again and close it. The next appointment, it will be obturation. If you keep the tooth for a longer time, that you are influencing, many bacteria will go inside. Now, when we have a diffuse swelling, and that's really a critical condition for the patient. And we can see the patient that he has started swelling in a way like that. We should think of the type of the space of the infection, where it can come from. We need to know also the attachment of the muscles, because that will show you how the spread of the infection will go like. In a case like this, could be coming from the buccal space or from the lingual space or from other spaces. In a case like this, if the patient can open his mouth, you might go and you can drain it, okay? And extend it to percussion and you go for, this is the only case that you will go for antibiotics, okay? There is swelling and there is a fever, okay, that will come to the patient. Incision and drainage, okay? And then occlusal reduction and pulpectomy and cleaning and shaping. We will talk about the antibiotics later on, okay, and when we describe it. This is the only case that you will go with the antibiotics. You will not go with any cases other than that with the antibiotics. Inter-appointment emergency, the causative factor, mostly with the gender, female is more. Necrotic pulps is more. Periradicular reducency is more. Any of these points, when it gets higher and you have more and more, that you have more prediction that there will be an inter-appointment emergency will come to you. Over-instrumentation, pushing debris and irrigation out of the apex. These are causative factors can cause you to have the patient as an emergency between visits. Now, the type that we have previously that initiated, it was a vital pulp, or we have initiated that was a necrotic pulp. Now with the vital pulp, we have incomplete debridement or we have a complete debridement. What is the difference? Incomplete debridement that you might did a pulpotomy or partial pulpectomy for that patient, or you did a complete debridement. He might come back again for an emergency. Or necrotic pulp, that was there is no swelling, and then he came back with a localized swelling. Then you might have, again, a diffuse swelling. That maybe it was a localized, then it becomes a diffuse swelling. So when we have a previously initiated pulp with a vital pulp, most of the time when the patient comes to you or call you, okay, that is have a discomfort of the pain, okay? It's not the pain that when he bites, no, it's a nagging pain and it walks him to sleep and it's a throbbing pain. That's the time that this is more worse than whatever if you did a pulpectomy for that case. Because now it's really an emergency, because to remove that tissue from inside the canal, you need to give an intrapulpal injection. So we need to do occlusal reduction, complete instrumentation, and analgesics. No need for antibiotics for these cases. Now, if you are 100% sure that you did a good cleaning and shaping, okay, and you're sure about that, most of the time these patients will come to you and they have some problem when they touch the tooth or when they bite the tooth. At that point, you may not make it a good clean or make it a good occlusal reduction at that point. So you need to make it more occlusal reduction and reduce the tooth more. And analgesic, you don't need to go back because that patient, he can look to you, he's aware of what you are doing. Now, for the previously initiated necrotic pulp with a localized swelling, most of the time when the patient, okay, you clean and shape for someone who didn't have a swelling, and he came back to you with this way of the swelling. It's localized, okay, and it's in the vestibule. So in this case, we do pus and drainage through the canal, then we complete the instrumentation, and we do the incision drainage after that, and we give analgesics. No need for antibiotics. You have to fill the canal with the calcium hydroxide. This will make sure the pus will be dried, and to the next visit you will go for obturation. When we have also a diffuse swelling, sometimes you might have it external, okay? You might go and do it from an external incision and drainage. These cases will need really a very close lookup. And these cases, the only will be recommended to go with the antibiotics. So incision and drainage, go with the complete instrumentation with the calcium hydroxide, analgesics, and antibiotics. These are the major things that you will have in these two types of the emergencies. Now, when we go with the post-obturation emergency, this is a vague and it's big, okay? And most of the times it's different, and it's different from me to Abdullah to Ubada. The decision is different. So we have many arguments. It could be surgical, it could be non-treatment, it could be wait and see if there is no treatment, or maybe extraction. So analgesics, one of them is sure for sure. Retreatment, if the previous treatment is inadequate, plus the calcium hydroxide, plus occlusal reduction. 2, we have incision and drainage. If there is a swelling, and antibiotics. We might go for episectomy or intentional palliation, or may go for extraction. So it's different, okay? It depends on the case and the situation. So these are mostly the emergency cases that will come to you in the endo practice. And you have to manage the time, and you have to be very focused and smart to choose and how to handle it very effectively and quickly. When we go with the local anesthesia, some will say the local anesthesia is just simple. Everyone will do it. Fine, okay, but you have to master it. Because most of the patients, when you come to your clinic, they look to your clinic as an open heart surgery. You look at it as a simple procedure, but they don't know that, okay? You have to take the trust of the patient. The patient will come to you with his apprehension and his anxiety, his fatigue, okay? And he has a tissue inflammation, and he has a previous unsuccessful anesthesia. All of this, if you think of it, is psychological. You have to gain the trust of the patient. The patient has to trust you. When he trusts you, everything will be easy for you to continue and to make this scenario, okay? Going from that of the mind of the patient, going to something like that. It's dreaming, but it's fine, okay? You have to gain it more. The emergency is not only about what you do, it's how to handle the patient. The patient, okay, we always forgot that there is, okay, there is a human being attached to the tooth. We always focus on the tooth, okay? But there is a human being. The feeling of that patient, okay, is very important. So psychological approach, we have to calm him down. If you have a patient that's holding the chair, okay, and holding his hand, that's the patient that you need to relax him. Sometimes I make my assistant to hold the patient, female hand, okay, to make her relax, okay? Don't panic, okay? Painless injections, okay? It's simple. Topical anesthesia, some of them will say it's not working, okay? Fine, I will take the chance, but it's more to be a placebo. Just dry the area, okay? 20% benzocaine gel for 1 or 2 minutes. Slow injection. 2-stage injection for the upper anterior is very effective. Just give a small drops, okay? And then withdraw your needle, then wait for a few seconds, then again, give that injection again, okay? That will be less painful, okay, for the patient, and you have a time to locate your tooth. When to anesthetize? You have to anesthetize every time. Some will say, I did the clean and shaping, okay, there is no pulp. Why I put, or to give anesthesia? You have to give, okay, there is a nerve ending around that tooth, okay? There is a nerve ending at the apical of the area. You're going to place a rubber dam, okay? There is a clamp, okay? All of the time you have to put local anesthesia. Maxillary, we should all not miss this thing, but you have to know a few facts about that point. The onset, that is the time that you might have the pulp to be numb, 3 to 5 minutes. But you have to put in your mind, okay, the anterior teeth, okay, declines after 30 minutes. That means the anesthesia will go down. And after 1 hour, you might not have anything. So if you're planning that you're going to stay for more than 1 hour, you will not wait the patient, okay, to say, I'm now having a pain, okay, no. You should like schedule yourself at 45 minutes, 15 minutes before the 1 hour, you might give him another injection. What's happening inside for the local anesthesia, that's why the upper is quickly kind of wash out because of the blood supply. For the premolar and the first molar, the declination is more, okay, 45 minutes and also after 1 hour. So if you're planning to sit with the patient for, let's say, 1 visit, okay, for 90 minutes, you are considering that you would give in between, okay, 1 shot, okay? Again, just to reassure, you don't want to have the patient that feel the pain during the treatment. You want him to be relaxed. This will make your life easier. The techniques, as everyone knows, the infiltration, posterior superior alveolar nerve block, infraorbital. Okay, these two techniques you have to master it, because if you have a swelling and you want to go beyond that swelling, you need to do it as a block. Now let's go for the first question. This is an interactive, okay? So I put some question. I want to see your feedback. Dr. Asim?
Okay, do you see the question now, Dr. Abdulaziz?
Yeah, I see it.
Okay, I'll give them 1 minute we have, mashallah, Abdulaziz, we have almost 1600 واحد now.
I hope I'm at their level of expectation.
Inshallah, inshallah.
دكتور عبد العزيز في كذا comments أو question that you're still going past يعني شوي نعرف there's a lot to cover لكن يعني هم يبغونك تهدي شوي.
fast slide ولا fast في التوك؟
لا في التوك.
دكتور عبد العزيز تخيل انهم 1600 ماشيين وراك الحين، امشي شوي شوي.
يا اخي
زي ايام الحج، امسك العلم حق الحمله وامشي كانك في الحج.
والله ما اوقف.
حتى الاسئله كثير يعني questions يعني there is a lot of questions يعني good questions. فان شاء الله في نهايه الريتس.
طيب I will give 10 seconds to close receiving answer. ما شاء الله we get so far 1200.
1200 ايش؟ question؟
1200 answered the question.
ما شاء الله.
Okay, طيب 1, 2, 3. Sorry for those who did not answer yet. I have to stop. And do you see the result, Doctor?
I see the result. I'm happy and sad. Happy because the information that I will give, it's something maybe new to them, and sad because they are not knowing that. So the answer is, we'll show it to you now. Can you close it, please? So
okay.
3 to 5 minutes is wrong. So 3 to 5 minutes is wrong. So for the mandibular anesthesia, okay, what we have is more. This is the lump, the lip numbness, okay? So 5 to 7 minutes, that's true, okay? To make your lip is numb, but it's not necessary that your pulp is numb. You will need 10 to 15 minutes, okay, to have your pulp to get numb. And that's the trick part, okay? It's not about the technique. It's not about the amount of solution, okay? It's not about, it's about the time that you can wait. And I will show you one of the most famous theories about this point. Now, the technique of the inferior alveolar nerve block versus other methods, let's say the echinosis or the open mouth technique, okay, it's the same. Some will say, okay, the mental nerve block, incisors and cross inversion. If you want to anesthetize the lower anterior or the canine, some will go with the mental nerve block. It doesn't work, okay? Some will try to do it, even the premolars, okay? In these cases, you need to go with the inferior alveolar nerve block. Infiltration with the Articaine, it's effective with the buccal side, even with the lower anterior. I will show you a support for that. The cross innervation, can we give double inferior alveolar nerve block? I'll say why we use it, okay? We don't need it, but is it possible? Because in their mind or our mind, that they will say, okay, the tongue, it will be swallowed, whatever. It's not true. One of the famous in the anesthesia is Dr. Stanley Malmet. You can give 2 blocks. Okay, doesn't make any difference. But do you need it? Okay, that's the question. Because if you have something alternative to give 2 blocks, one with the Articaine on the other side, but you will not go and do the mental block from 2 sides. Now, this is the most famous theory about the problem that we have in the inferior alveolar nerve. We have this thing what we call the central core hypothesis. The diameter of the nerve itself, it's a big nerve. If you want to intentionally cut that nerve, you can't, okay? It's not easily. Inside that nerve, okay, the supply for the molars is different from the supply to the premolar and the anteriors. And that's the thing, that you need more time, that the anesthesia can go through it, okay? And then you have more of the anesthesia will go and anesthetize the area. That's why it's the last thing you'll have, the anterior will be anesthetized. But even the molar will need more time. That's why I have the tissue around it, the lingual and the other from the lingual branch. But the last thing you'll have it to be anesthetized is the pulp. So you need more time. So I'll give you a simple video. It's very basic, okay, about how to go and to give the anesthesia in a simple way, but I'll give you simple tips. So this is mostly the innovation that's inside. We have the coronoid process that you go and you just press, and you can see the ramus, that you can see the size of the ramus that you have, and you can see the diameter, how much you need to go, and where is the middle of that. You go with the depression that you have inside. You'll go slowly, and then you'll touch the bone, okay, and then you'll aspirate. If you have a fast needle touch, you'll go back and go forward. And you'll inject slowly for 1 minute, okay? Don't push it all together. And at that time, okay, talk to the patient. Make the patient relax, okay? It's not a horror movie, okay? It's just a local anesthesia. Then after that, you will not go and do the inferior alveolar, the long buccal. All of this one. So the full needle, okay, or the full carpule, okay? It will be for the inferior alveolar nerve. You will wait for 10 to 15 minutes. Then after that, you'll take your endo eyes and you put it on the tooth. If the patient didn't feel any pain, that's a good sign. Then you can go and you can give the Articaine. You might give the Articaine from the buccal side for the molars, okay? And that will also increase your success to numb the tooth. For the lower anterior, okay, we have also good support. This one you can go. This is, I did it with Dr. Abdullah Deeb and Abdulaziz Asmir. They are now R4 in the endo program, one in Riyadh, one in Jeddah, proud of them. So we did this study, okay, on the Articaine with the lower anterior, and it was very effective. So if you want to go and do the anteriors, okay, the lower 6, you don't have to give a mental, okay, you can give infiltration, and you can go with an Articaine. Now, what else can happen if this didn't work? We have supplemental anesthesia. So we have the periodontal ligament injection, we have the intraosseous anesthesia, and we have the intrapulpal. So the periodontal ligament, in general, okay, we choose 4 points: mesobuccal, mesiolingual, distobuccal, distolingual. And we go till it's have the tight contact inside the interligament, and then we press, okay? It will need, I'll give you a time, okay, for 10 to 15 minutes, just as a pulpal anesthesia. What's the mechanism of action for this type of technique? Some people think that the local anesthesia will transfer all the way to the apex. It's not true. It works that the local anesthesia will go through the bone, okay, the pores of the bone. It will work like an intraosseous. So if this didn't work, then we go with the intraosseous anesthesia. We have this X-tip from a brand from Dentsply and so many other brands. It comes like this way. We attach it to the slow speed. There is a protective cover. We remove it, and then we go and we anesthetize the area that we go through. How we do that? We go to the distal of the tooth that we want to work on, except for the second molars. For the second molars, you can go for the mesial side. And between the interpupilla, we'll go 2 to 3 millimeter, okay, 4 millimeter here below. And then you will go with the slow speed all the way till the cancellus. And then you will stop. This piece will be attached to the area. Then you have you can take a short needle, and then you can apply. Half carpule is enough. That's very effective. Some of the studies say it's 100% can be effective. So if this didn't work, most of the time you're already in the pulp. So at that point, you need to go and do the intrapulpal. So at that point, with the intrapulpal, the fluids, okay, when you see it in that tooth, okay, this is an effective way of doing the intrapulpal. The intrapulpal need a pressure. So it works more on the pressure. So you need to make your needle inside the canal, and it is very tight. So when you press the pistil of the syringe, you feel like there is a pressure, okay? There is nothing is coming out. And this study by Dr. Walton, he compared saline with the local anesthesia solution. Both are effective. So it's really on the back pressure. So if you don't have a back pressure to do the intrapulpal injection, it doesn't go into work. It's very painful for the patient, but it's very effective to remove the tissue from inside. So this is the flow chart, how your strategy of going if you have a problem with the patient to anesthetize. So you go with the inferior alveolar nerve block, the lingual block, and the long buccal filtration. If it didn't work, then you go with the interligamentary injection. If it didn't go work, you will do it again and repeat it again. If it didn't go well, you will go back with the intraosseous. Or you may go from the beginning with the intraosseous. All of this will give you a way to go to the intrapulpal. Most of the time, I don't think you will need these, okay? You might go only with a step one. If you have any problem, you're already in the pulp, you'll go with the intrapulpal if you need it. So this is about the local anesthesia. For the analgesics, talking about the analgesics from a point, okay, pre-treating the patient or pre-medication the patient with the whatever type of medication, the patient will come to you and he's relaxed of the pain, and this will reduce the post-operative pain, and even the, some will say it will be effective for the local anesthesia, but it's not true. It's an indirect way the patient is relaxed and he is calm and his pain threshold is not like slow or less as is expected. So it's give you a chance. That's why it's more effective during the treatment. And it reduces the incidence of the flare-up because most of the patients will be less painful when they have the procedure. Now, what's the recommendation for these type of medications? I cannot go in detail for the medically compromised patient, but I have a lecture with the Saudi Endodontic Society next Thursday for these type of patient medically compromised. But let's be simple. In a way, if this patient can't tolerate the ibuprofen or the aspirin, okay, then the strategy or the best recommendation is going with the ibuprofen, 200 to 400 milligram. If the patient has a severe pain or moderate pain, he will go with the ibuprofen from 400 to 600 milligram, or you have a combination, what we call the analgesic cocktail. So it's like 400 with the 500 acetaminophen, which is the paracetamol. Or you might go with a higher dose of 800 ibuprofen with the acetaminophen or paracetamol with 1000. This is a big dose, so you might make between them 3 hours. If the patient cannot tolerate the ibuprofen, then you go with the acetaminophen or paracetamol for 500, or you might have a combination with a codeine, and that's what we have in the pharmacy or the market called Solbadine. But in Solbadine, there is some ingredient, sometimes it's interactive with another drugs, is the caffeine. So it's acetaminophen plus codeine plus caffeine. You have two types of Solbadine. You have the capsule and you have what is called, you can dilute it in the water, and that's 10 milligram of caffeine. So you have to be careful what you choose for your patient. So this is about the analgesics. When we go with the antibiotics, these are the only indication that you go and you are recommending the antibiotics. Fever, malaise, lymphadenopathy, trismus, increased swelling, cellulitis, osteomyelitis, immunocompromised. When you think of all of these conditions, it's all affect your immune system. So it doesn't relate to your periapical area or the type of the tooth or whatever the condition. No, it's related to your immune system. These are the indication of the antibiotics. So when you go with this chart, patient have a symptomatic irreversible pulpitis, pain, pulp necrosis, acute apical, all of these are no. When we can consider it is when we have acute apical abscess with medically compromised patients, acute apical abscess with systemic involvement, when you have a fever or malaise, or we have a progressive of the infection. That means the infection started to be going from no pain or no swelling, then we have a diffuse swelling. So these are the only indication that you go and you give the antibiotics when there is a systemic involvement. Okay, when there is the immune system, I need to support the patient. Okay, is now have less immune. I need to support it. Now the periapical area, when we consider it as this area, antibiotics with the periapical lesion. Some saying that when you have a lesion, then I have to give antibiotics. It's not true because there is no microcirculation. There is a lack of blood that will go there. The infection is inside the tooth. What's outside, which is the periapical radiolucency, this is the inflammation. This is your body reaction to the byproduct of the bacteria. So the antibiotics will just pass by with the blood supply and would not ever go there. Unless if there is a swelling, okay, and then your immune system will go down, then you need to support the immune system by the antibiotics. That's the only reason you are using antibiotics. Otherwise, periapical lesion and antibiotics is not related. There is no relation between them. So the efficacy of the antibiotics. This is a good study by Dr. Baumgartner. He has only the endobacteria, and he chose some of the major antibiotics. I choose these 4 because they are the most used in our country. Amoxicillin, clavulanic acid, clindamycin, and metronidazole. The numbers that you see on the bars is how much this antibiotics killed bacteria. So we have the amoxicillin, he killed 91%. Amoxicillin clavulanic acid, which is the augmentin, is 100%. Clindamycin, 96%. The metronidazole is 45%. So if you want to have a first choice, only amoxicillin, you will not go immediately to amoxicillin, to clavulanic acid. 91 is enough, more than enough. If you have a patient who is allergic, you'll go to clindamycin. Metronidazole, never use it. I'm talking about the endo infection. It's a lousy drug. It has the most side effect, and it has the most interaction with the medications. So don't ever use the metronidazole with the endo infection. Amoxicillin for your first choice, going with the amoxicillin clavulanic acid as a backup if it didn't work. If you have a patient who's allergic to amoxicillin, then you go with the clindamycin. So for question number 2, Dr. Asim.
You see the question, Doctor?
Yes.
Okay, everyone, please take 1 minute to read and answer the question. Your participation is really appreciated. We'll give you 1 minute. For the participant, we have announcement between, inshallah, Dr. Abdulaziz and Dr. Abadi lecture. We'll just take the winner from yesterday webinar, inshallah. So I will give you 20 seconds more. The question is, antibiotics can be changed to a stronger type if the patient's symptoms worsen after how many days? 1 day, 2 to 3 days, 5 to 6 days, or 1 week. So I got so far almost 1,300 response. Okay, 10 seconds.
Awesome. Most of them, they're asking about the question. They don't see it.
في 1200 واحد جاوب على السؤال.
اوكي تمام.
فاللي ما نشوف معناته يمكن مشكلة عنده. فنعتذر اللي ما طلع لهم السؤال، سوري يعني. Okay. So, do you see the result, Doctor?
Very good. 2 to 3 days. Excellent. So 1 for them, 1 for me.
So this is the green is the orange is the majority. So almost like 460 or 500, let's say 35% of your audience have chosen the right answer. The rest still need to change their opinion about this. Okay.
So I'll give just a clarification for the 2 slides more, and I'm done. Okay.
Okay.
So going for the so the duration, we heard about a complete course. This is in the medical. It's not in the endo or dental. Okay. We don't have something called complete course because the endodontic infection doesn't rebound. So when medical people, they have a chest infection, they give the antibiotics. And that's why they have to take a full course, okay, for 5-7 days till the infection goes. For us, okay, the antibiotics is not going for the infection. It's not going there because if you did a good cleaning and shaping for the root canal, I'm just giving the antibiotics only to support the immune system. When you want to change, is after 2 to 3 days. Let's say I prescribe for 500 amoxicillin. 2-3 days, the swelling is getting worse, and if the case become worse, I need 48 to 72 hours, which means after 2 to 3 days, you can switch to a stronger, antibiotics. Now, what's the recommendation? This is a tweak or something that you can use. So the amoxicillin, 500 milligram with clavulanic acid, that means 875 milligram, clindamycin 300. There is something called a loading dose. Loading dose, that means you can double the first dose. So a patient comes to you with a swelling, and you want to make the antibiotics go faster in the bloodstream or goes to the highest efficacy of the dose, you can double the first dose. So instead of the first dose to be 500, it will be 1,000 for the first dose. Then the second dose will be 500, 500. We can do the same thing for the augmenting, because the first dose by itself, it's bigger dose. It's 875. Clindamycin, yes, we can go and double that dose. It will be 600. Then the maintenance dose or the second dose will be 300. This is most or ever the emergency. Thank you very much.